All right, good to be here. So there's a little bit of crossover. I think it's very hard to avoid some crossover with the other talks. And then you guys actually had a little bit of this that was mixed in with the renals yesterday, with the renal occlusive disease. So I'll try to concentrate on the things that aren't too redundant. So just to outline basically, we'll talk very briefly about etiology indications for treatment, talk about endo-revasc. I'll talk a little bit about the techniques, at least the ones I use for that. Talk about open revascularization, show you a little bit of the results for the outcomes of both, and look at a little of the very little comparative data between open and endovascular treatment of visceral occlusive disease that's out there, and then just talk a little bit at the end about patient selection. So a whole bunch of causes of mesenteric ischemia. 95% of what you'll see is due to atherosclerosis, at least for chronic mesenteric ischemia. So as Dr. Sheehan just said, chronic mesenteric ischemia is rare, but actually atherovisceral vessels is very common. So you see this artery here. Anybody know what that artery is called? This was an angiogram I did for a lady for claudication. And then you see this. Anybody know what that artery is named? Yeah, but anybody ever know the specific name of the artery, actually? It takes on a name. We call that the meandering mesenteric artery. All right, so that is collateralization between the IMA and the SMA, which indicates severe SMA, probably occlusion, or at least high-grade stenosis. And I think the thing to know about most atherosclerotic visceral disease is this is aortic spillover disease. So this is disease that's at the origin of the vessels on the aorta that spills into the orifices of the celiac, the SMA, and the IMA. Treatment. It's pretty straightforward. All patients who have chronic mesenteric ischemia need to be revascularized. This is a universally fatal problem without it. It's pretty straightforward. And the goals are to reduce their pain naturally, prevent infarction of the bowel, that's why it's ultimately universally fatal, and help them regain their weight and nutrition. On the other hand, there's no role for prophylactic revascularization, even if you happen to diagnose 3-vessel critical disease. Some people have reported this, but I think you'd have not much of a leg to stand on to revascularize for asymptomatic disease, even in the setting of terrible anatomy. The other thing to remember is that these are not patients who can be managed with TPN, and then just kind of, if you want them to have any longevity. They can't wait it out on TPN as an attempt to keep them with good nutrition. It won't work. It'll be uniformly fatal. So there are some unsettled issues. How many vessels do you treat? We'll talk a little bit about that, and then how do you do it, endo versus open. So actually, endotherapy for chronic mesenteric ischemia first reported back in 1980. And now this has evolved, I think in most people's hands, to primary stenting with a balloon expandable stent in general for the most common orificial diseases. Some people do report the preference to an expandable covered stent, and the approaches for access are generally percutaneous, although an open retrograde approach through the SMA in the setting of an open exploration and the need for a bowel resection is often reported. Technically actually a little bit difficult, but can be done in some settings. So what's happened over the last 20 years until about 2010? This is a series out of the Mayo Clinic. You can see black bars are open surgery, white bars are endo-revascularization. I mean, just look at the switch that's occurred from 1990 to 2009. Pretty interesting. And so that gets to the point of what Dr. DiRoberta said in terms of maximizing every opportunity you have for open revasc. Back to endo a little bit. So generally the technique is an aortogram with an AP, then a lateral view to diagnose your orificial disease. And if you decided that it's amenable to treat it, then the approach that I would generally use is 6 French sheath, either in the groin or in the brachial artery. And then I tend to use a so-called no-touch technique, which is to go with a guide cath, 6 French guide cath through a 6 French sheath of a shape that's going to get you a good approach to the origin of the artery. And then that limits you to an 014 system. So if you're going to work through a guide cath, you're going to be working 014, which is probably what you're going to do anyway. If you want to stay with a sheath, bring a sheath to the origin of the vessel, in order to do something that requires an 035 system, that's fine too. You can treat it that way as well. But I think many people would go, you have a little bit more options, I think, if you go with an 014 system. So generally, these are very tight orificial stenoses. So you hear, this is an instance where I brought a Lima guide cath to the origin of the celiac artery, heparinize, get through it with a wire. Too tight to do a primary stent, at least in my opinion. So you need a channel to get your stent out there. Pre-deal with a 2 to 3 millimeter PTA balloon. Repeat arteriogram. Mark up your lesion, and then go right to a balloon expandable stent placement. And that's usually a 6 or 7 millimeter stent in the origin of the celiac and the SMA. One key is you have to hang a little bit of the stent into the aorta. You need to hang about 2 millimeters of stent into the aorta itself, because that's really the only way, if you think about it, you're treating that orificial spillover disease into the origin of the vessel. I think one of the decisions going in is femoral or brachial access. I would say probably, I think many people, and myself included, I probably do 80% from brachial, because usually you have this down-sloping angle, certainly to the SMA and often to the celiac, that's better coming from the arm. If it's sort of a 90-degree angle and not too acute, then the groin, you can do it from the groin for sure. Here's an example from the arm, so a lateral arteriogram, and then you see this is kind of a funny dissection kind of lesion, a little bit unusual. But you can see how the angle of an MP guide cath coming from above, from the arm, gives you a really nice swooping angle right into the origin of the vessel. And it's a lot easier to do that than to deal with a very tight turn coming from the groin. But that's really where your CTA comes in. So that's where, doing a CTA beforehand, not only does it help you make the diagnosis, it tells you about the best approach. So what's favorable for endo? Similar things to the lower extremity. If it's short, if it's not highly calcified, if it's not a chronic total occlusion, although chronic total occlusions can be done, but I would say they can only really be done endo if you have a little lead point into the lesion. If you have a flush occlusion, I mean, it's like, where do you start? That's very difficult to do. So the opposite things are unfavorable for endo. So if you look at bare metal stenting, what are the results? So there's not a ton out there really, but these are relatively recent series, sort of from mostly through the course of the 2000 to 2010. Very few series have any follow-up beyond a year, but the ones that do show patency of about 65 to 90%. So you never see 90% patency past 1 year. That's the best you're going to see, and that's only out to about 1 year. And I'll show you a couple other studies that talks about the results. So here's a very good paper from Cleveland Clinic. Talked about endovascular, their experience with endovascular treatment of stenotic and occluded vessels. And these are 87 patients, mostly treated with bare metal stenting. And you can see here, so get out to 1 year, they had a primary patency of 65%. So very similar to a lower extremity situation where, yes, you can be successful, but there's going to be some surveillance and some maintenance potentially involved. So, in their hands, 65% at 1 year. With additional therapy, they're able to, second interventions, they're able to maintain at least a good short-term secondary patency. But I think that's what you should expect. In this particular paper, they showed that they were able to do stenotic vessels and occluded vessels with equal success. Just a little bit about covered stents. The data here is not very good, and I think it's actually an area that could be studied further. But there are some groups that because of the prevention of in-stent restenosis, that highly advocate using covered stents instead of open-celled balloon expandable bare metal stents. So here's an example where you have this is a patient who I took care of who had a CTA. The diagnosis was mesenteric ischemia clinically. CTA showed a severe disease. But I did an aortogram to see if, maybe the CTA was overcalling and to see if there was actually an endo option. So this is through the visceral segment here. And this is a case that's, at least in my hands, I couldn't do endo. You can't even tell where the origins of the vessels are. And in that instance, when you don't see that, well, then you need to establish what are your targets for open bypass. And that's where you need to get in delayed angiograms. 10, 15 seconds later, holding their breath, getting the right view to see where things reconstitute. Because in that kind of low flow state, you're not going to see that on the CT scan. And you don't want to go into an operation sort of figuring out where your target's going to be. That will not be a successful operation. So here you can see on delayed views a very subtle reconstitution of the mid to distal SMA. This was a lateral view on the right, and then you kind of rotate to a more AP view, as Dr. Sheehan said, to see the more distal reconstitution. So what are your options from here? I'm going to avoid the whole embolectomy for mesenteric bypass. It's a different thing. But here's, if you kind of take visceral disease as a group, I think here's the kind of skill set the things you want to think about. So you have to be able to do embolectomy for acute disease. Some approach towards mesenteric bypass, either antegrade or retrograde. Be nice to have some ability to do transaortic splanchnic endarterectomy. That's a tough operation. That's the kind of operation you want to get your senior partners involved and take advantage of every opportunity in this segment. And then the management of median arcuate ligament syndrome, people have talked about a lot. We'll skip that. So the open revasc, here's the most common one, is an antegrade aortoceliac and aorto-SMA bypass. The nice thing about the supraceliac aorta is even in the setting of good diseased visceral arteries, it's usually disease-free. So it's usually very soft for clamping and for sewing and proximal anastomosis. The trick here, celiac, this is a very short bypass to the celiac. So many people use a pre-made bifurcated graft, like a 12x7, even a 10x6, because it lends itself nicely to bringing one limb of the graft to the origin of the celiac and the second limb under the pancreas out to the, I'd say about 4 to 5 centimeters out the SMA. Probably the most common approach. Definitely prosthetic in this scenario, unless you have infarcted bowel. And that's why Dr. Sheehan said that infarcted bowel with acute on chronic mesenteric ischemia is very difficult to deal with. The options you want to use, you can't use in an infected field. So it's a very difficult problem. Here's this just shows the exposure, which has been shown before. The image on the right there shows actually usually how you can get to about 3 or 4 centimeters from the origin of the SMA by actually mobilizing the ligament of Treitz, mobilizing the duodenum to the right, and you sort of end up on the sort of left posterolateral aspect of the SMA. And if they're not too big, you can creep up pretty proximally on the SMA there, and you really end up about 3 to 4 centimeters off the origin of the SMA. It's a good approach to establish a target for a bypass. So if they can't tolerate that, let's say you have a patient you think's too sick, you don't think they can take a supraceliac cross clamp, well then you have to find an alternative source of inflow. Most people would use the iliac artery, or maybe sometimes the distal aorta, but generally one of the iliac arteries, to do then a retrograde mesenteric bypass to that same segment of the SMA that I just described. So here's how it lies, and here's how you want to see this done. So this is the picture that I showed you with the reconstitution of that distal SMA, and you can see on the CT scan how far distal that really is. And then you can see there the reconstruction bringing it out to that mid-SMA. You always want to use ringed PTFE here because you're forcing this graft to take this very odd loop. I mean, you do the bypass, and then all the bowel flips back. So that is very prone to kinking. So you need to do usually a 6 or 7 ring PTFE. Here's another entity you'll see called coral reef syndrome. And on the image on the left, that's not contrast, that's calcium. So this is a very specific pattern of disease that's more commonly seen in women, where there's huge, bulky atherosclerotic plaque right at the origin of the celiac and the SMA. And this is a tough thing. This is really diagnosed basically with a CT scan. You might not see this. I mean, you would see obstruction of the celiac and the SMA, but you might not see this just doing an angiogram alone. The treatment here is transaortic endarterectomy. That's best done usually through a medial visceral rotation. You can see the line of division there. Behind the spleen, behind the kidney, everything comes over from left to right. And then you can come down on the origin of the vessels. And then transaortic endarterectomy, where a so-called trapdoor incision is made, the origin of the vessels are visualized, endarterectomy is performed. Sometimes, as you can see in this picture upper right, sometimes the disease will actually obliterate or get into the wall of the vessel distally, and you actually might have to do a separate patch on either the celiac or the SMA to repair it, and then close your trap door. It never takes a vein patch because the aorta here is pretty good caliber. So just see the hit the high points here in terms of I think here's where we are just in terms of data to summarize. So there's no level 1 data in this area. All the existing literature is series of open or series of endo. And there's obvious selection bias here, based on the anatomic complexity of the lesions. The endo series, the lesions are much, less extensive than the ones in open. And so, just go to the conclusions, and we'll maybe stop here. So, I think that, basically, you have for chronic mesenteric ischemia, you have to have a very aggressive interventional stance. You need to supplement the nutrition even with TPN pre-op, but only as a bridge to get them ready for your operation. I think at this point, you look at all the data, and the data for open bypass is 90–95% patency at 5 years. I mean, it's very good. Of course, the morbidity of the operations is much higher than an endo revasc, but the durability is much better. So I'd say at this point, open revasc is most durable, but you need to look at the patient's overall cardiopulmonary risk to make sure they can take that type of revascularization. But ultimately, I think the anatomy will determine what your options are. And I think at this point, endovascular therapy, it intuitively avoids all the major morbidity, but the surveillance is so important because you're not going to have the same longevity in your revascularization. And I think there's actually a lot of potential here for research if it's an area if you guys are interested in. I think maybe one of the key questions that we don't have much data on is, does endo actually burn bridges for open surgery? So if you get your stent out too far, that kind of thing. Are you burning bridges for a potential, are you making an open revascularization which might prove necessary? Are you making it harder or impossible? And I think there's still a lot of room here to improve the endo options for this disease. So thank you very much. Appreciate it.